Hello and welcome to the next episode of Towards New Futures. My name is Vineet Malhotra, a series of shows presented by ActionAid Association and NewsX, where we discuss with policymakers, change makers and grassroots workers on how we can create a post-COVID reset, which provides all of us with hope, much needed in these times. If the image of the first wave of COVID-19 in the year 2020 was of the returning migrant, the second image wave in 2021 was the oxygen cylinder. This represents how our health system was unable to cope with the surge of COVID-19 cases throughout the country, not only in specific locations. According to WHO data, the peak was reached in the month 2021 with more than 27 lakh confirmed cases in week ending on the 10th of May 2021 and 28,982 deaths in the week ending 17th May 2021. Thankfully, cases and deaths have reduced, but there is a danger of more waves coming and that the final victory will elude us till timely and universal vaccination is achieved. Then there is the danger of other pandemics hitting the world. A bleak scenario indeed that we are dealing with. Well, it can be argued that no country in the world can actually be fully prepared to handle an emergency like the COVID-19 pandemic. But considering the continuing danger of additional waves of COVID-19 and the threat of new pandemics, perhaps the time is ripe to scale up investment in health services. The call to make health and healthcare a fundamental right for all citizens may be the best way to ensure this happens. The National Health Mission of the Government of India envisages achievement of universal access to equitable, affordable, and quality healthcare services that are accountable and responsive to people's needs. We have today a panel of eminent experts who will help us understand how best this could be achieved. Joining us on the program is Dr. Abhay Shukla, National Co-Convener of Jan Swasthya Abhiyan or People's Health Movement India. Indrani Gupta, Professor and Head, Health Policy Research Unit, Institute of Economic Growth. Esther Maria Selvam, Associate Director, ActionAid Association, leading the organization's work in Kerala, Tamil Nadu and Puducherry. Debabrat Patra, Associate Director, ActionAid Association, leading the organization's work in Odisha and in relation to humanitarian responses to emergencies. Sarika Sinha, Director of ActionAid Association, who leads the organization work in campaigns and policy. Welcome everybody, and let us start with a discussion on the issue of vaccination. COVID-19 teaches us that no one is safe till everyone is safe, and that timely universal vaccination is the key to the final victory over the COVID-19 pandemic. Esther, let me start by asking you a question. Share with us about the work that ActionAid has undertaken to promote universal vaccination. That seems to be the only way going forward when it comes to dealing with COVID-19. Everything else has been tested and it doesn't work as much as the vaccination does. Well, in some cases, the vaccination also has not helped. People who have been vaccinated with full doses have come back by recontracting COVID-19. Esther.
Yeah, thank you. Unlike the first phase of COVID-19, the second surge of COVID-19 has severely affected the rural areas. We realized that in ActionAid, people lacked access to reliable information on vaccination. There was a lot of misinformation on the safety of vaccines. In fact, that actually hesitated many people in getting vaccines. In the phase of limited access to proper health services, vaccine hesitancy could be the thin line between life and death. So in ActionAid Association, we have actually worked tirelessly to promote universal vaccination while simultaneously ensuring vaccine access to everyone. In that sense, we have two-pronged strategy in place, encouraging people to get vaccinated through vaccination awareness campaigns. We always related vaccine awareness campaign along with the relief distribution, also providing access to vaccine for the most vulnerable social groups. In fact, wherever we have done our relief work, like for example, to reach out the Solpan workers, the transgender community, fish workers, we have combined vaccine awareness campaigns. As on 15th of July, we have almost reached around 11 lakh people with awareness on COVID-19 vaccination. And also always we have shared the various information pertaining to where the vaccination centers are available across different locations in India. Also the number of dosages available so that people can actually avail on the same. We used varied methods, local and traditional methods, in terms of reaching out to the most remote areas to bridge the information gap caused by the digital divide. In fact, many forms of campaigns to raise awareness on vaccine we have organized. Like, for example, cycle yatra, mobile vans. These are some of the campaigns, just to mention few, to raise awareness on vaccine. In fact, we have actively engaged the various community members with whom we have been working, as well the volunteers with whom we have actually engaged to make information available in almost about 150 districts across India and is as many as languages as we could. We also extended help in getting remote communities as well as those left out in getting registered for vaccination. Through our efforts, we were actually able to ensure almost over 70,000 persons from marginalized communities could access vaccine. And these included varied vulnerable groups, like, for example, who have been struggling to get access to quality healthcare, like vulnerable groups such as homeless persons, persons from nomadic and denotified communities, tribal communities, Dalit communities, domestic workers, those who are in the frontline workers like sanitary workers, marginalized Muslim communities, domestic workers, construction workers, migrant workers, and even trans persons. In fact, we have enabled, facilitated our community members to participate in rapid assessment to understand their perception. And we have made use of every opportunities that was available. Like, for example, in the month of June on the 16th, while we commemorated International Domestic Workers Day, we advocated with our local member of Legislative Assembly to make a vaccine available for the domestic workers with whom we have been working. In fact, on that day, in the state of Tamil Nadu, around 120 plus domestic workers were able to access a vaccine. So in this way, like, we've been working in many forms to raise awareness as well as to ensure vaccine to the most excluded and marginalized community in our society. Thank you.
Esther, also talk about, what do you think are going to be the challenges when it comes to achieving universal vaccination? And what are the steps that perhaps ActionAid can also take in ensuring that the people who are, in a way far off or not really, excited about taking the vaccine also see the importance in taking the vaccine?
Well, as of today, the statistic shows only 10.8% of the total eligible population have received both the doses of vaccine. In fact, ActionAid, as part of our any kind of humanitarian response that we do, we always reach out to the most excluded and most marginalized and to the remote place. So in that manner, raising, people had a lot of misinformation about vaccine, as well as they were told, misinformed about the safety of vaccine. So ActionAid actually engaged in reaching out to those kind of remote places where interior places, there are places where, for example, in the state of Tamil Nadu, Irula tribals, they used to live in the agricultural farms where people won't even know that they exist, couple of houses will be there. So ActionAid reaches out to those kind of places because so that they won't be left out of this process of accessing vaccination, raising awareness as well as demystifying various myths pertaining to the vaccine, because that is most important. In fact, from our experience, what we have understood, one of the comedian actor who has been actually advocating for vaccine for people to access, unfortunately, he died in the process. So after that process, we found that people were so much hesitant Now, like through a very campaign process on raising awareness, we were able to actually demystify the various facts related to vaccination. Now the challenge before us is like availability of vaccines. So that needs to be actually attended to. So that is what is the most crucial things. Like if you take a state of Tamil Nadu, they have actually taken many innovative and creative steps, like reaching out to the persons with disability in their respective homes, and also like so that like they will be able to access vaccine. So in that way, reaching out to the most remotest place as well as most excluded community, ActionAid has actually taken varied measures, and in the future also we'll be taking the same.
All right. Well, we're going to slip into a short break, but on our way out, we're going to play out this conversation we had with the Minister of Medical Education, Madhya Pradesh, Mr. Vishwas Kailash Sarang. Sir, appreciate you speaking with us. First up, tell us, what has the government of your state done to ensure that there is universal access to health?
सबसे पहले तो हमारी कोशिश है कि थर्ड वेव ना आए, और उसके लिए बहुत ज़रूरी है कि हम संक्रमण की चेन को डेवलप होने से रोकें, उसको हम ब्रेक करें। और इसलिए मध्य प्रदेश में हमारे मुख्यमंत्री शिवराज सिंह चौहान जी के नेतृत्व में उनके निर्देश पर हमने ये सुनिश्चित किया है कि सेकेंड वेव की पीक में जितने हम टेस्ट करा रहे थे, आज भी हम उतने ही टेस्ट करा रहे हैं। ऑल्दो अभी मध्य प्रदेश में कोविड की स्थिति बहुत नियंत्रण में है। हमारे रोज़ में 10-12 पॉजिटिव केस आते हैं, पर उसके बाद भी हम 70,000 का जो हमारा आंकड़ा है टेस्टिंग का, हम 70,000 की रोज़ टेस्टिंग कर रहे हैं। हम कॉन्टैक्ट ट्रेसिंग पर बहुत ध्यान दे रहे हैं। हम एक पॉजिटिव केस यदि आता है तो 30 लोग, उससे जुड़े हुए 30 लोगों की कॉन्टैक्ट ट्रेसिंग कर रहे हैं, जिसमें ये सुनिश्चित कर रहे हैं कि हमारा पॉजिटिव केस स्प्रेडर के रूप में ना आगे बढ़े। उसके साथ ही वैक्सीनेशन को लेकर हम बड़ा एक कार्यक्रम कर रहे हैं। आपने सुना ही होगा, मध्य प्रदेश में हमने 21 जून को 17 लाख लोगों को वैक्सीन लगाने का एक रिकॉर्ड बनाया, और 10 लाख लोगों को हम लगभग रोज ही वैक्सीन लगा रहे हैं। पर यदि थर्ड वेव आती है तो उसकी भी हमने हेल्थ पॉइंट ऑफ व्यू से पूरी तैयारी की है, और हमने ये सुनिश्चित किया है कि हम मध्य प्रदेश में हेल्थ हमारा इंफ्रास्ट्रक्चर है, उसके इंस्टीट्यूशनल वाइज हम प्लानिंग कर रहे हैं। चाहे वो प्राइवेट सेक्टर का हमारा हेल्थ का इंफ्रास्ट्रक्चर हो या गवर्नमेंट सेक्टर का हमारा हेल्थ का इंफ्रास्ट्रक्चर हो, हम संस्थागत प्लानिंग कर रहे हैं। हमारे अस्पताल में बिस्तरों का एनहेंसमेंट की बात हो, आईसीयू बेड्स के एनहेंसमेंट की बात हो, पीडियाट्रिक डिपार्टमेंट के स्ट्रेंथन करने की बात हो, पीकू जो पीडियाट्रिक आईसीयू है उसको बनाने की बात हो, इन सब विषय पर हम काम कर ही रहे हैं। हमने ये सुनिश्चित किया है कि पूरे प्रदेश में हम प्राइवेट सेक्टर और गवर्नमेंट सेक्टर की इंस्टीट्यूशनल वाइज प्लानिंग करेंगे। ऑक्सीजन जनरेशन, ऑक्सीजन स्टोरेज, हमारे हेल्थ वर्कर की ट्रेनिंग, हेल्थ वर्कर का रिक्रूटमेंट, हमारे दवाइयों का प्रोक्योरमेंट, इन सब बातों पर हम विस्तृत प्लानिंग के साथ काम कर रहे हैं।
And sir, also tell us, in light of the lessons that have been learned during the pandemic, what has been the government's plan for the future?
दुर्भाग्यपूर्ण यदि किसी बच्चे के माता और पिता की मृत्यु हुई है तो हमने मुख्यमंत्री बाल सेवा योजना मध्य प्रदेश में लागू की है, और ऐसे बच्चों को हम 5,000 रुपये महीना पेंशन दे रहे हैं। हमने अनुकंपा नियुक्ति की व्यवस्था की है। यदि कोई अधिकारी कर्मचारी की मृत्यु हो जाती है, चाहे वो गवर्नमेंट में परमानेंट हो, टेम्परेरी हो, डेली वेजेस पर हो, इवन आउटसोर्स का भी यदि कोई कर्मचारी है तो उसके परिवारजन को भी अनुकंपा नियुक्ति मिल सके, इसकी व्यवस्था हमने मध्य प्रदेश में की है। उसके साथ ही हमने ये भी सुनिश्चित किया है कि हम ज़्यादा से ज़्यादा लोगों को समयबद्ध इलाज उपलब्ध करा सकें। हमने मध्य प्रदेश में कोविड से लड़ने की जो हम प्लानिंग कर सकते हैं उसको हमने सुचारू रूप से किया है। मैं यहाँ पर एक बात और इंगित करना चाहता हूँ, जैसे माननीय प्रधानमंत्री जी ने दीपावली तक जो मुफ्त अनाज देने की योजना लागू की है, उसमें मध्य प्रदेश सरकार ने भी सहयोग करते हुए अन्नोत्सव के माध्यम से ये सुनिश्चित कर रहे हैं कि हमारी 28 कैटेगरी हैं कोविड के समय जिनको आर्थिक रूप से बहुत परेशानी हुई, उन्हें हम मुफ्त में अनाज भी हर महीने दे रहे हैं।
Let us start the discussion on the issue of vaccination, and that is something we've spoken of in the first segment, but now we also turn to the issue of community health structures that could make health as a human right meaningful to vulnerable communities, and how it should meet surges in demand which are caused by epidemics and pandemics. So we're going to talk about community health and health as a basic human right. Devabrat Patra, could you share lessons from the humanitarian response to the Ebola epidemic in Sierra Leone in 2014, and what would serve as the context for COVID-19 and what we have been going through and what we are still a part of? Devaprat?
Yeah, I went to Ebola response program in Sierra Leone, which was done by ActionAid International in 2015. And Ebola, as you know, was much less prevalent than COVID-19. In Ebola, around 11,000 people died in West Africa, that includes Sierra Leone and other neighboring countries. But there are some uncanny similarities with Ebola and COVID-19. The COVID appropriate behavior and the Ebola appropriate behavior is almost the same. We have to wash our hands frequently, physical distancing, and so on. But some of the lessons which you could have learned from Ebola pandemic was regarding the dissemination of information in the community. Firstly, when I went there, there was no proper dissemination of the information that this sort of Ebola appropriate behavior has to be adopted by the community. And second, we work with Neighborhood Watch Committee, which included traditional chiefs, religious heads, village elders, and these were the people who actually influenced people to adopt the Ebola appropriate behavior and not to take part in the cultural festivals, including the death rituals and so on, which also exacerbated the Ebola pandemic. And another 2 points was the children were very badly affected post Ebola pandemic, and that we are going to witness very shortly. And there was a study showing that around 25% children did not go back to the school after school reopened after the Ebola pandemic. And the last point is that there was a lot of stigma about on the people who actually recovered from Ebola, and they found extremely difficult to revive their livelihood post Ebola, and that's what we are also experiencing in India. We also experienced a lot of stigma and discrimination at the initial stages. And now the challenge is post-COVID, how to recover the livelihoods, how to recover the sources of income in the families which are affected by COVID.
Right. Devaprat, also talk about the context of COVID-19 and what has ActionAid Association done to support public health infrastructure.
Yeah, as you said, the second wave was more of a medical emergency. So we first started with giving life-saving medical support to various hospitals. We started with basically establishing helplines, help desks. We established around 81 help desks, which helped around 33,000 people, and provided psychosocial counseling to 15,000 people. Through the helpline, we provided information regarding the availability of beds, hospitals, oxygen, medicine, free food services, and so on. We also supplied oxygen concentrators to various public hospitals and community health centers. We have supplied more than 6,500 oxygen concentrators so far. We've also set up oxygen plants in COVID care center in Noida, and 2 more oxygen plants are in process of setting up in UP and Manipur. We also supplied PPE kits, oximeters, infrared thermometers, digital thermometers, and other medical supplies to the various hospitals and to the volunteers, frontline workers who are working in the COVID response. Esther spoke about the awareness and program regarding the COVID response. And we have reached around 15 lakh people through our awareness campaigns, which was not only about vaccination, but also about spreading awareness about the COVID appropriate behavior and so on. We have also set up around 23 COVID care centers in various states with the help of district administration in remote districts with little access to quality healthcare. So this is in nutshell what we have done so far in ActionAid. And the process is still on, and we are still supplying medical equipments and medical supplies to various hospitals all over India.
Okay. Dr. Abhay Shukla, if you're there with us. Dr. Abhay Shukla.
Yeah.
Sir, I would request you to not turn off your video, even when you're not speaking, sir.
Okay.
Keep it on at all times. Dr. Shukla, during the COVID-19 pandemic, responses of public health systems in different states have been very different. Certain states like Kerala, despite having large numbers of cases, have managed to keep COVID fatality rates lower than other states. What are the lessons to be learned from this diverse state responses to COVID? What is the learning over here?
Yeah, so I think the COVID entire pandemic has also been a huge opportunity for learning. Of course, it's been an unprecedented human tragedy, but there's also a lot that we can learn from the different responses of various state governments during the pandemic. One feature which has not been adequately probably noticed so much is the huge variation in case fatality rates across different states due to COVID. Means out of 100 patients who get COVID, how many actually die? In Kerala, the case fatality rate is 0.5%. In Gujarat, it's 1.22%. In Karnataka, it's 1.26%. In Maharashtra, it's 2.11%. The case fatality, Maharashtra and Kerala are the two states with the largest number of cases currently. And there's a differential of 4.2 times. And when you translate this into actual numbers of deaths, it's a difference of tens of thousands of excess deaths or deaths which perhaps could have been avoidable. And there are huge health system lessons which underlie these differences. So I have a whole range of statistics, which I can share, but what is the reason for these differences? These are not accidental. And even if you say that there may be some underreporting, overreporting, and so on, still, let's compare Kerala and Maharashtra. And let's see what is the difference. Both Kerala and Maharashtra are in a similar socioeconomic bracket. In fact, all the four states that I have mentioned have a per capita GSDP between 2 to 2.5 lakhs. So they're in the same broad category. Private sector healthcare, the level of number of per capita private sector beds is similar in Maharashtra and Kerala. What is different? There is a huge difference in the presence of the public health system. Huge difference. So Maharashtra has 6 government doctors per lakh population. Kerala has 15. Maharashtra has 0.4 public hospital beds per 1,000 population. Kerala has 1.1, 2.5 times difference. I can go on about per capita public health spending, about levels of utilization of the public health system, etc. I have all these statistics, but to cut the long story short, there's a huge difference in the level of functionality of public health services, even when the private sector presence is similar and the socioeconomic conditions are similar. The striking difference is in the levels of public health system functionality. So the big lesson there is functional public health services right from the primary healthcare level, and especially at the primary healthcare level, which lead to better testing, better outreach, early detection of cases, early and proper referral, and of course, after that, initiation of treatment at an early stage and rational treatment in the public health system. This entire chain of processes leads to lower COVID mortality. And the converse is true, that if there's a failure at each of these levels, cases will be detected late, they land up late in the health system. Many of them will go to the private sector where there is a lot of irrational care and more people will die. So the huge lesson is we need to make public health services far more robust, functional, well-resourced, well-staffed, adequately reaching out to people, especially at the primary healthcare level. It's literally a question of life and death. That is the lesson of COVID, that public health services are the lifeline of any society, and we ignore them at our great peril at the cost of tens of thousands of lives.
Then, Dr. Abhay Shukla, how do you think we should move forward to make the right to health meaningful, most vulnerable and the marginalized communities in our country, because they are bereft of any privilege?
Yeah, here I'd like to say that in COVID, everybody was marginalized. It's not a question of us versus them. Even the middle class, we talked about oxygen cylinders, even the middle class, perhaps for the first time since independence, realized how important public health services are. And people died, unfortunately, because of lack of adequate public health services, even in big cities like Delhi and Mumbai and Pune and Bangalore. So to move forward on the right to health and the right to health care, what I would say is that the traditional human rights framework, we can use it, but we also need to expand it. So the traditional human rights framework tells us that the state has an obligation to respect, protect, and fulfill. And this is correct. It's an important, but I will now turn this around and say, let's start with fulfill. Fulfill means that the state has an obligation, an undeniable and undilutable obligation to put in place the entire range of facilities and services for health which are required by any community and any population. And which means that for the right to health to be fulfilled, first and foremost, health systems have to be completely functional and adequate to meet the needs of the population. And today in India, as we know, that we are far, far behind this. Today we have one government hospital bed for around 11,000 population. Actually we need something like 2 hospital beds per 1,000 population. So there are a lot of differentials. So the point is that public health services being fully functional so that they reach out to each and every community and are able to deliver the entire range of services is the first precondition for fulfilling the right to health. But I think in the discussion on infrastructure, I think perhaps other speakers will speak about that. I'll move to the second now, which is often ignored, and that is the right to protect. The right to protect is from non-state actors. Who is the big non-state actor in the health sector? It's the private sector. 70% of healthcare utilization in India is from the private sector. We have allowed privatization on a huge scale in this country. And it has gone more or less completely unchecked and unregulated until now. And the COVID epidemic shows us what are the consequences of that. Huge. Initial stage, there was denial of care. Many private hospitals just shut down their shops. They refused to treat COVID patients. Second stage, when patients started coming in and they allowed huge amounts of overcharging. I mean, bills, we have been documenting these as Gems Fast Abhiyan. Bills for COVID care ranging from 5 lakhs, 10 lakhs, 15 lakhs, 20 lakhs total bills. And per day, bills in the range of 1 lakh rupees per day. I mean, these are astronomical charges which have absolutely no justification. People have been completely devastated. So where is the state? Where is the state to regulate, to protect people from this? So regulation of the private healthcare sector is an absolute other precondition for fulfilling the right to health in this country. And the third, I'm not talking about respect in detail because it's well known, but I would say we need to add a fourth, and that is the state has an obligation to equitably collaborate with community. And where that equitable collaboration takes place, as it has happened in Kerala to a large extent, there the health outcomes are very different. And when the state acts as a punitive agent, as in Uttar Pradesh, if you say I don't have an oxygen cylinder, you will be punished. I mean, actually, people are giving information to the government which they should welcome and act upon. So we need to also put in place systems of community-based monitoring and planning, systems of community accountability regarding the public health services and also the private healthcare sector, where people have a voice to shape how health services are being delivered in an accountable way and which fulfill people's needs. If that is not there, the right to health will also not be fulfilled. So all of these different components are important, and I think the COVID epidemic has shown us how each of these is especially important. So it's now time to wake up and ensure that the right to health is ensured in a comprehensive manner. I conclude with 2 points. One is about while privatization has failed as a policy in the healthcare sector in India, and the COVID epidemic has shown us how this has happened, the NITI Aayog has recently come out with a document which recommends accelerated privatization of healthcare in this country. It almost pretends as if the COVID epidemic experience did not exist. And it recommends large-scale additional international investments in private investments in healthcare, greater financialization of the healthcare sector, and handing over of public hospitals to private actors with state subsidization. So from passive privatization, now the state is moving towards active and proactive privatization of healthcare, which is a disastrous direction. If there's anything that will damage the right to health in this country, it is such policies which should be immediately challenged, exposed, and completely scrapped. And the second is, at the same time, we have positive, initiatives of right to healthcare acts in certain states being considered, being discussed. We need to put the right to healthcare centrally on the political agenda in this country today. In the light of the entire COVID experience, there has been a huge mass movement across all sections of people, which will stand up and say, we need the right to healthcare, we need functional public health systems, we need regulation of the private healthcare sector, and we need systems of community accountability and participation, which are all essential to fulfill the right to health.
Absolutely, and that was extremely well articulated. What we're going to do is we're going to dip into a short break, and on our way out, we'll make you listen into a conversation that we had with the Tamil Nadu Health Minister, Mr. M.A. Subramaniam. Be right back.
We are joined by the Tamil Nadu Health Minister, Ma Subramaniam. Sir, இந்த மருத்துவ வழியாக கொரோனா எப்படி தமிழ்நாடு தாண்டிச்சு சார்? மருத்துவ வழியா கொரோனா வந்து எப்படி தாக்கல் பண்ணீங்க?
இல்ல புரியலையே.
இந்த மருத்துவ வழியா எப்படி இந்த கொரோனா வந்து முதல் வேவ் இரண்டாவது வேவ் பாப்பா போடுமா? பாப்பா போடு. உலகம் முழுக்க எல்லாரும் எப்படி அதை ஹேண்டில் பண்ணாங்களோ அதே மாதிரியான கையாடல் தான் இதுலயே நடந்துருக்கு. மக்கள் எல்லா மக்களுக்கும் சேர்ற மாதிரி மருத்துவ நடவடிக்கை என்ன மாதிரி எடுத்துக்கொள்வது? ஏழைங்களுக்கும் பணக்காரங்களுக்கும் என்ன மாதிரி மருத்துவம் எல்லாத்துக்கும் சேருது?
அதான் இப்போ இந்த தடுப்பூசி போடப்படுகிற பணி என்பது எல்லாருக்குமான ஒரு பணியாக இருக்க வேண்டும் என்பதுதான். இப்போ தனியார் மருத்துவமனைகளிலும் கூட சிஎஸ்ஆர் பங்களிப்புடன் தடுப்பூசிகள் இலவசமாக போடப்பட்டு கொண்டிருக்கிறது. எனவே இதில் பாகுபாடு இல்லாமல் அனைத்து தரப்பினரும் பயன்பெறுகிற அளவுக்கான நடவடிக்கைகள் எடுக்கும்.
வரப்புகிற காலத்தில் 3வது அலை வருதுன்றாங்க, டெல்டா வேண்டு அதிகமாகன்றாங்க, அதுக்கு என்ன நடவடிக்கை கவர்மெண்ட் எடுக்குது சார்?
இல்லை 3வது அலை வந்தாலும் அதை எதிர்கொள்வதற்கான இந்த மருத்துவ கட்டமைப்பு என்பது சிறப்பாக
ஃபியூச்சர் பிளான்ஸ் இருக்கா சார்? மெடிக்கல் வழியாக வந்து தமிழ்நாடு கவர்மெண்ட்
இல்லை அது என்னெல்லாம் பண்ணணுமோ பெட் வசதி கூடுதலாக்கி இருக்கிறோம், ஆக்சிஜன் வசதி கூடுதலாக்கி இருக்கிறோம். இதுதான் ஃபியூச்சர் பிளான்.
நன்றி சார். So well, we had this Tamil Nadu Health Minister Ma Subramaniam talking about the COVID status and the corona situation in Tamil Nadu.
Now we're going to talk about strengthening infrastructure, which is going to help make the right to health meaningful even in pandemic conditions. Indrani Gupta, at the policy level, what do you think needs to be done to ensure that health as a human right becomes not only achievable but meaningful to even the most excluded and marginalized communities in our country? That seems to be a perennial problem. Please unmute yourself. Please unmute yourself. Indrani Gupta, you're muted.
Am I audible now?
There you go, yeah.
Yeah, thank you very much. And Dr. Abhay has made my job actually much easier because what he said just resonated with me. Basically, the Constitution of India does not expressly guarantee a fundamental right to health, but there are multiple references to public health and then the role of the state in the provision of healthcare to citizens. There's Article 15 that guarantees right to equality and non-discrimination. There's Article 21 on right to life and liberty. So there are enough provisions, there are others, and there are enough provisions in the Constitution that should have ensured all citizens have access to health services. But this has not happened, and in any case, we cannot wait for health to become a fundamental right for us to ensure equity and equality in our health care. So adopting a human rights-based approach within our current health system would require policymakers, first of all, to treat health and other socioeconomic inequities at par. We can't choose which inequities we are going to be addressing. Health inequities should be actually at par with other kind of inequities, first of all. Second, we have to hold the state accountable for violations of not being able to provide these services. We don't do enough of that. in the absence of legal solutions, this approach would require significant community mobilization and civil society engagement, especially by and for those who are vulnerable in our country. One lesson we have learned from the HIV/AIDS epidemic is that globally countries have tackled the access issues by mobilizing the civil society to such an extent that there has been pressure points formed and the governments had to come in and do the right things. So civil society mobilization, grassroots mobilization, I was very happy to hear what ActionAid has been doing. These are going to be really critical at this point to get the government to be accountable. But we cannot do this if our health infrastructure is not there. So suppose we are able to get them to come and demand services, where are the services? So here I would say that what Dr. Abhay said, there are serious shortfalls in both infrastructure and health personnel. We know that our population-based health personnel norms are also not being fulfilled. And we do not have a coherent approach to medical supplies and consumables. For the health coverage system, which is supposed to stop us from extreme financial devastation, we have an extremely fragmented health system. We have multiple schemes offering a variety of coverage, both in scope and in excess. For example, we have a small section of the population with very generous coverage and the rest of the population either with meager or no coverage. Our universal health coverage planning is not really up to the mark, I'm sorry to say, and neither is it universal in scope, nor is it universal in coverage. We cover IPDs mostly, the hospitalization, but we don't cover preventive care, we don't cover outpatient care, etc. So that can't be called universal health coverage. Dr. Abhay said, regulation has been, the track record in India is quite dismal. We have allowed the private sector to grow completely unchecked in an environment of low financial protection and a dysfunctional public sector. Obviously, people will go and spend out of pocket. So that's not amazing. So overall, what do we have to do? I think what has not happened is that we have to go back to the drawing board, meticulously assess the current gaps in terms of availability, accessibility, and quality and coverage of the various moving pieces in the country. And this has to be done in one point I want to really emphasize is that this has to be done in the true spirit of cooperative federalism, given that health is a state subject. Health sector reforms also take time. Most of the countries that have now gone over to universal health coverage have taken 3-4 years. So let's take time, but do the reforms. But the reforms can be done in an incremental way, time-wise, but the scope of the reforms should be completely comprehensive. And that can only happen if somebody is sitting there and figuring out what went wrong. But finally, all this can happen only with a huge jump in health financing. And, to fix the system, we need finances. And while we are going through difficult times, both in the economy and in the health sector due to COVID, we need to prioritize health. What has not happened so far is that health has not been prioritized in the country, but now is the time to prioritize health and ensure that we have enough funding to go on to the next level of being prepared for a pandemic.
Right. And Rani Gupta, in view of the threat of the new pandemics and epidemics, how should health infrastructure be envisaged and, more importantly, designed?
Well, I'm an economist, so I can talk about, and I work on health systems. So infectious diseases and outbreaks basically need a resilient public health system. And what do we mean by a resilient public health system? We need a strong, very strong surveillance mechanism, adequate health personnel, sufficient medical supplies and equipment, continuous course correction, learning, training. This is a dynamic process. So a resilient health system is basically able to prepare for and effectively respond to crisis, at the same time maintaining its basic core functions, which continuity of essential health services during a pandemic time is critical. So you not only want to meet the pandemic demand, you want to meet the usual demand that the country has in normal times. Now, pandemic prevention management being a public good, the onus is on the government to put in place such a resilient system. There are studies that show that India scores low on pandemic preparedness. That's not surprising. You just heard, we have, if you look at the rural health statistics that the government puts out, it is really dismal. We have shortfalls in doctors, specialists, radiographers, pharmacists, lab technicians, pediatricians, etc., surgeons. We also have serious shortfalls in infrastructure, sub-centers, Now it's called health and wellness centers have come in, PHCs, CHCs, and many of these facilities are operating without the Indian public health standards norms. We don't have regular water supply, electricity, roads, etc. We have also seen during COVID time acute shortages of PPE and other essential medical supplies, ventilators, oxygen. Now, when we started the pandemic, when the pandemic started in India, India had almost zero capacity for producing PPE and other medical supplies. However, we saw that during about the first 5-6 months, significant progress was made in the procurement and augmentation of domestic manufacturing capacity, and also now in oxygen. It's a bit puzzling why it couldn't have been done earlier on. The medical device industry, for the longest time, till the pandemic struck us, was about 80% dependent on imports. Now, production capacities are being ramped up. Is a country cannot deal effectively with the pandemic by trying to fix its health system in real time. Each life is precious, and to lose lives because of poor and unavailable products and services is unpardonable, I think. The fixing has to be done much ahead of time.
Absolutely.
In addition to finances, the overhaul of the health system in the country requires reforms that are fundamental in a number of areas: medical education, primary health care, referral system, infrastructure and personnel, public health cadre, health services administration, etc. The list is long. Instead of undertaking a series of incremental reforms in each of these areas, we have been initiating schemes and programs with new schemes thrust on the population without changing the underlying flawed fundamentals. Basically, I think we need some serious data on how much the government spent during the COVID pandemic to fix these various parts in real time. We do not have data yet, and I think transparency in how the government functions is going to be critical. So far, we know government spending has been about 1% out of its GDP, and we compare very poorly with other hard-hit countries like UK, France, and Germany. Okay, if we don't want to look at those developed countries, we can look at South and Southeast Asian countries like Thailand and Sri Lanka. They also spend more. And middle-income countries, to which we belong now, spend 3% of their GDP, and we spend about 1% of the GDP. So there is a need to increase finances.
Okay.
And I want to say that while both the center and the states need to work on these reforms, the role of decentralized policy making, where states can take decisions that are in their best interests, need to take center stage, especially since health is a state subject. The fact that, Dr. Abhay just mentioned that Kerala has had very low mortality rates because their health system has been very functional, and they have been, from day one, we have seen Kerala as an example as a state that functions. Of course, they have been hard hit by COVID, but they have performed and responded well. So the states have to we have to learn lessons from the states, and the union government does have that role of taking best practices from other states and telling the rest of the country, this is how things should be done. So the government really requires to provide the finances and regulatory framework, which is completely lacking. As Dr. Abhay pointed out, there is no regulation whatsoever in our country that will allow actors to have a level playing field. Okay. So states need to take charge of their own health sectors as well. That's where I want to stop.
All right, we're going to slip into a short break, but on our way out, we're going to play out this conversation that we had with the Rajasthan Health Minister, Mr. Raghu Sharma. Sir, appreciate you speaking with us. First up, tell us, what has the government of your state done to ensure that there is universal access to health?
जिस ढंग से एक्टिव केसेस बढ़े, एक दिन में 18,300 केसेस आ रहे थे और पूरे स्टेट के अंदर करीब 2,12,000 एक्टिव केसेस हो गए, तो हमने राजस्थान सरकार ने ANM, आशा सहयोगिनी, आंगनबाड़ी कार्यकर्ता, इनकी टीम बना के डोर टू डोर सर्वे कराया। जो ILI सिम्टम वाले केसेस थे, खांसी, बुखार, जुकाम के, उनको चिन्हित किया गया। करीब 18 लाख लोगों को चिन्हित किया गया जिनके ये लक्षण थे। तो उनको प्राथमिक स्टेज पे ही कैसे उपचार दिया जाए, उसके लिए एक मेडिकल किट तैयार की, उसमें सारी दवाएं थी। उन दवाओं को टाइमली उनको दे दिया हमने। तो जो इनिशियल स्टेज पे लोग संक्रमित भी हो गए होंगे तो उनका उपचार हो गया, और उससे जैसे सेकंड पे वेव में एकदम केसेस बढ़े, उससे एकदम डाउन भी हुआ एकदम उनका ग्राफ। तो मैं समझता हूँ कि एक तो हमारा ये प्रयोग बहुत सफल रहा। गांव-गांव में कई बार तो 2-2, 3-3 बार सर्वे हो गए, लेकिन डोर टू डोर सर्वे से जो लोग लक्षण वाले लोग थे, खांसी, बुखार, जुकाम के, उन लोगों का टाइमली ट्रीटमेंट हो गया। सेकेंडली, जिस ढंग से वॉर फुट पे यहाँ काम हुआ, क्योंकि सबसे ज़्यादा ज़रूरत पड़ती है ऑक्सीजन की, और ऑक्सीजन की किल्लत पूरे देश के अंदर थी सेकेंड वेव के दौर में। हम 3 मंत्रियों को मुख्यमंत्री जी ने दिल्ली भेजा, क्योंकि भारत सरकार ने जितने भी मेडिकल लिक्विड ऑक्सीजन बनाने वाले प्लांट्स थे देश के, उनका अधिग्रहण कर लिया और राज्यों को कोटा तय करने लग गए। तो इतनी भारी किल्लत थी, आप ये सोच के चलो। हमें ज़रूरत 615 मैट्रिक टन की थी और हमें मिल रही थी केंद्र सरकार से 400 मैट्रिक टन। तो इतनी कम ऑक्सीजन होने के बावजूद भी जिस ढंग से हमारे ब्यूरोक्रेट्स ने, मेडिकल की टीमों ने मैनेजमेंट किया, वरना हाहाकार मचा हुआ था। 2 घंटे की ऑक्सीजन रह गई, कहीं फ़ोन आ रहा है 4 घंटे की ऑक्सीजन रह गई, कोई जगह 6 घंटे की ऑक्सीजन, सैकड़ों मरीज भर्ती, उनकी ज़िंदगी और मौत का सवाल था। गोवा में क्या हुआ, कर्नाटक में क्या हुआ, दिल्ली में, सब जगह सैकड़ों लोगों की ऑक्सीजन की कमी से मौत हुई। राजस्थान में हमने एक भी व्यक्ति की ऑक्सीजन से मौत नहीं होने दी।
And sir, also tell us, in light of the lessons that have been learned during the pandemic, what has been the government's plan for the future?
विशेषज्ञ चिकित्सक बताते हैं कि थर्ड वेव आएगी, और अगर थर्ड वेव आई तो सबसे ज़्यादा प्रभावित करेगी बच्चों को। और आप जानते हैं कि अभी बच्चों के लिए जो 18 साल से कम उम्र के हैं, कोई टीका बना नहीं है, ट्रायल चल रही है, तो वैक्सीनेशन उनका हो नहीं सकता। ऐसी परिस्थिति में हमने राजस्थान में जितने बच्चों के अस्पताल है, उनके जो नीकू है, नियोनेटल इंटेंसिव केयर यूनिट या पेडियाट्रिक इंटेंसिव केयर यूनिट या SNCU, इनको हम मजबूत कर रहे हैं। वहाँ ICU के बेड बढ़ा रहे हैं, वहाँ पे सेंट्रलाइज ऑक्सीजन पाइपलाइन लगा रहे हैं, ऑक्सीजन जनरेशन के प्लांट लगा रहे हैं, मल्टी पैरा मॉनिटर सिस्टम बेड बढ़ा के वहाँ लगा रहे हैं। और राजस्थान में 332 कम्युनिटी हेल्थ सेंटर CHC वो हमने सेलेक्ट किए जो रूरल एरियाज़ में पूरे स्टेट के अंदर, उनको हम स्ट्रेंथन कर रहे हैं। हमने इक्विपमेंट की लिस्ट बनाई है कि मिनिमम इक्विपमेंट इस CHC में होने चाहिए, वहाँ कितने मौजूद हैं और कितने हमको और देने हैं, इसके गैप का एनालिसिस किया जा रहा है अभी। सेकेंडली, उन CHCs में 4-5 बेड का ICU हम डेवलप कर रहे हैं, सेंट्रलाइज ऑक्सीजन सिस्टम वहाँ भी लगा रहे हैं और ऑक्सीजन जनरेशन के प्लांट वहाँ लगा रहे हैं। थर्ड चीज़, जो कमी हम जूझे सेकेंड वेव के दौरान ऑक्सीजन की किल्लत की, उसको दूर करने का गंभीर प्रयास किया। करीब 400 जगह राजस्थान में ऑक्सीजन जनरेशन के प्लांट लग रहे हैं। NHM लगा रहा है, हमारा LSG डिपार्टमेंट लगा रहा है, हमारा मेडिकल एजुकेशन डिपार्टमेंट लगा रहा है, हमारे जो विधायक कोष से लग रहे हैं, कोई दानदाता लगा रहे हैं। कुल मिला के राजस्थान में 40,000 ऑक्सीजन कंसंट्रेटर हमने परचेज किए हैं। 1,000 मैट्रिक टन ऑक्सीजन अपने लेवल पे राजस्थान उत्पादन करने की क्षमता पैदा कर लेगा थर्ड वेव से पहले। तो जो ऑक्सीजन की किल्लत हमने झेली, जो हमारा इंफ्रास्ट्रक्चर उसको मजबूत, करीब 550 बेड का तो लोकार्पण मुख्यमंत्री जी ने कर भी दिया बच्चों के अस्पताल में। आगे भी काम चल रहा है। थर्ड वेव से पहले राजस्थान में कोई दिक्कत नहीं रहेगी।
We are almost towards the end of our show, and Sarika Singh, I believe ActionAid Association plans to again take up the issue of health as one of its strategic priorities. How is this going to play out on the ground, and what are the kind of challenges that you are bracing for?
Thank you, Vineet. I think, in medical terms, because I think when we began, you said very clearly that the face of COVID this time was more medical and more of death. I think what it did was do a vivid autopsy of our society and expose the weak links. So while everyone was marginalized, as it has already been said, we know that it was the poor who died a lot because of inaccessibility of health services and refusal for treatment. So the fragility has been exposed a lot. It's also the ubiquity of power, you see, the ways in which we mystify power, and invisible people like migrants, like poor people, like women who were not there and never took the visible or the center stage. So that was also something that was being protruded out quite a bit. And if you look at the whole character of COVID and the COVID appropriate behavior, as it's called, it has a very strong classed and gendered character. So, how many of us in slums or in rural areas from where women fetch water can actually wash our hands very frequently, or use a sanitizer, which is 250 rupees for a small bottle of 100 ml? How many of us can actually practice physical distancing when 7 of us live in a crowded house, which is not even big enough for 2 people? So these are things that got exposed out. Now, in terms of ActionAid, I want to emphasize on 2 things. One is a very strong people-centered approach for which we are going to campaign and advocate. And the second, of course, is a very robust public health system for which we will not only campaign, but also work at the level of policy. So now when it comes to people, I think when we talk about a people-centered response to this pandemic, we know that it will be the precarious bodies in the center. And we are going to acknowledge that there is regional, sub-regional, social, and economic division of inequality. So we know that, and it crosses across class and caste and gender and ethnicity. So, when people take a subjecthood in this matter, it will involve a lot of campaigning around their rights, which is something that we have been engaged in, and which is something that we are going to pick up very strongly vis-a-vis health. The second thing is, the institutional arrangements sort of replicate the social hierarchy. It's also that, when 70% of the entire population goes to private sector, and sometimes people spending all their money that they have are paying for for health services is very deeply entrenched. And that will take a lot of time for us to change, to establish that health is a right. It is something that should have been given to us as a welfare state. It is very deeply enshrined in our constitution. So we will be looking at community-based interventions in terms of surveillance, in terms of detection, in terms of isolation, in terms of quarantine and referrals, but not in a manner as to stigmatize people that you got COVID because you did not accept and behave in the COVID appropriate manner. So it's not that people want to do that. Now, secondly, we are also going to engage a lot into very grounded researches, which is something that we have been doing. So we know that there's a little bit of data on migrants, but there's very little data on children or women survivors of violence, on the most precarious population and how they got impacted. And that is something that we propose to engage in very strongly. And the third, vis-a-vis people, I want to say that, there are deeply rooted structural poverty. So it's not just that you did not have health services. So there is malnutrition, there is food insecurity, and we are going to work a lot around the resurrection of this squalid livelihoods. So we know that the most poor people are the ones who have lost their livelihoods most. So that's the thing on end block when it comes to people. Now I want to talk about public health next, and I think a lot of the discussions have been very, very, to the point where it should have been. And we know that everyone was marginalized. And I think ActionAid acknowledges that we need to support the public health system. So a system that is designed to be minimalistic. So what Professor Gupta says that, it's certainly not aimed towards universalization. So it needs to be structurally transformed, and that just by supplying health equipments or oxygen concentrators is not going to do that. So we need to have a very robust health system, a complete overhauling. And when I say infrastructure, I also mean that at every level we need new personnel. So it's not just PHCs and health and wellness centers. So we do need to look, and we are going to advocate around the underinvestment in public health infrastructure. We welcome the new investment, but we still feel that there is a yawning gap. There needs to be a strong regulation of the private health sector, which I think got away scot-free, got away unaccountable, and there is no single authority to...
I hate to interject, but we've completely run out of time. I just want to take some concluding thoughts from Dr. Abhay, and then we're going to wrap up. Dr. Abhay, if you can hear me. Any concluding thoughts from you, sir, on the conversation, the very interesting, the very galvanizing, introspective conversation that we have had?
Yeah, First, I'd like to correct one fact which I had mentioned, and that is that basically about the number of government doctors per 1,000 population. So India has one government doctor per 11,000 population, and the WHO norm is one doctor per 1,000 population. So we have 11 times less what is required, way behind. So I'd just like to sort of conclude that on 2 points. One is what is to be done. I think the analysis from all the panelists has been excellent and it's quite clear. What is the next step? The next step is to collaboratively build a powerful right to health movement from the grassroots. In Maharashtra, we have initiated this process. I'd like to share with you as Jan Swasthya Abhiyan, Maharashtra, as Jan Arogya Abhiyan, as we call ourselves. We have conducted nearly 20 district level workshops across the state, even in the COVID situation. Of course, online mostly. And we have brought together very large numbers of what we can call non-health activists on board to collaborate for a right to health movement. I think this is some kind of a small achievement. And it's because people are responding. Today, across the world, people working on Dalit rights, on women's issues, on farmers' issues, on with workers, they're all saying, yes, we also need to work on health. Health is something which is a priority. So building those very wide collaborations for a powerful right to health movement is essential. And secondly, I would like to say that so far, the social movements and health movements have almost left the private sector untouched, almost. And I'm being self-critical here also. Now we have certain opportunities in the post-COVID situation to demand patients' rights. Okay. And I'd like to share with you that the Jan Swasthya Abhiyan has launched a national PN on patients' rights and regulation of private healthcare, which has been accepted by the Supreme Court just last week. So I'd appeal to all of us to come together for both supporting this legal regulation of private healthcare, implementation of patients' rights, the Patients' Rights Charter of the National Human Rights Commission, and ground level campaigns in the coming period.
Okay. All right. Unfortunately, we would like to continue this conversation, as invigorating as it may be. We have run out of time, but a lot of learnings for not only me, but to all the viewers and hopefully the government as well, and whoever is watching this program. Thank you, everyone, for being a part of this very, very interesting conversation. Thank you so much.
For more such videos, subscribe to the NewsX YouTube channel, hit the bell icon.